Paramita, for the opportunity. So I will share my slides. Okay. Okay. Is it visible, Doc?
Yes.
Yes, very good.
Okay. Okay, thank you. Good evening, professors, doctors, and fellow residents. So my name is Carennia, and I am a third stage resident from Universitas Indonesia. Thank you so much for the opportunity. And tonight I will be talking about steroid-induced glaucoma in children. So here is the case. An 11-year-old girl who came to us accompanied by her mother on June 2023 with chief complaint of itchiness of both eyes, accompanied by uncomfortable sensation since 2021. So starting from January 2021, she felt both eyes were itchy and it was worse at night compared to daytime. And besides her, both eyes were also felt watery, red, produce discharge, hypersensitive to light, and also deteriorating visual acuity. So her mother brought her to a sham and he gave eye drops to reduce the inflammation, but unfortunately they didn't recall the name. She denied any history of allergy, asthma, or glaucoma in the family. Back then at 2012, this girl was actually a healthy child without any visual complaints. And at last in June 2023, because of worsening complaints of both eyes, she was referred to our hospital, but she has been prescribed timolol, latanoprost, acetazolamide, and potassium L-aspartate since 5 months ago. But her mother didn't know whether her child's intraocular pressure was high. So on the initial visit, we found that her right IOP was high, and even though she was on anti-glaucoma medications from her previous hospital, we could also see a papillary reaction on both tarsal conjunctiva and also transverse dots on both corneas. And gonioscopic examination revealed an open angle in both eyes. Therefore, we assessed her with steroid-induced glaucoma of both eyes, complicated cataract of both eyes, and vernal keratoconjunctivitis of both eyes. So from our division, glaucoma division, we gave her anti-glaucoma medications and also planned for implanting GDD for both eyes in general anesthesia. We also consulted this patient to the pediatric ophthalmology division, and they gave her navazoline and also carmelosodium for both eyes. So I proceed to her first surgery, which was performed on 4th August. The preoperative clearance was normal. And here is the preoperative IOP. The right eye was 16 and the fellow eye was 15. And postoperatively, we stopped all the anti-glaucoma medications for the right eye, and we gave her levofloxacin and also prednisolone acetate every 2 hours for the right eye. Here's her condition on the following day. So her visual acuity was 6/24 with IOP raised to 33. And we could see from the picture that the implant was actually at the supertemporal area with subconjunctival bleeding and multiple figural sutures, but the black was invisible. And if we take a look at the AC, it was flat. We could see the tube at the 11 o'clock, which pressed the iris with cells +4 and also flare positive. But we didn't find any lens corneal touch. So we decided to taper down the prednisolone acetate per 3 hours for the right eye. And we added the other anti-glaucoma medications and also atropine sulfate for her right eye. On postoperative day 3, the IOP dropped significantly to 3 millimeter mercury, and her visual acuity also decreased from 6/24 to half meter finger counting. But we didn't find any sign of leakage, and we decided to stop the timolol and brisolamide eye drops and give her methylprednisolone 2 times 8 milligrams orally. So at 1 week postoperatively, her right IOP was actually good without medications, and her visual acuity was back to 6/30. Here is the picture. So the AC still flat with tube at 11 o'clock, which pressed the iris. However, if we took a closer look on her left eye, the IOP was significantly high until 54 millimeter mercury. Hence, we plan for VGI implantation also for her left eye. So at 2 weeks after the surgery, the IOP went back to 22 millimeter mercury and visual acuity 6/45. And the left eye was 24 with anti-glaucoma medications. So we decided to stop the levofloxacin, the prednisolone acetate, methylprednisolone, atropine sulfate, and we continued the anti-glaucoma medications. And also we plan for the VGI implantation on the left eye and injection of mitomycin C for the right eye in general anesthesia. So actually, here's the recap of her right IOP. Maybe I will skip this part. And then we proceed to her second surgery, which was actually scheduled 3 weeks after her right eye. So on August 30th, we performed the second surgery of VGI for the left eye, and we injected mitomycin C inside the flap for her right eye. The IOP preoperatively for the left eye was 16, and the right eye was 9 millimeter mercury. Postoperatively, we stopped the anti-glaucoma medications for left eye, and we give levofloxacin and prednisolone acetate every 3 hours for the left eye, but 3 times a day for the right eye. So day 1 after the left surgery, the
recording in progress.
The IOP went back to 9 millimeter mercury for the right eye. And we could see the implant at the superior temporal area with medium bleb with slightly increased vascularization, but with a good coverage. On the anterior chamber, it was deep, and we could see the tube at 11 o'clock without endothelium and iris touch. On the left eye, the visual acuity decreased to 2 meter finger counting, and the IOP raised to 50 millimeter mercury. We could see the conjunctival injection, ciliary injection, and the implant was at superior temporal area with multiple finger sutures. The bleb was low, diffuse, with high vascularization, with a good coverage. The AC was deep. The tube was found at 1 o'clock without the iris touch with cells +1, and there was no flare, but with coagulum in the lumen. So we continued the prednisolone acetate for the both eyes, and we gave her the anti-glaucoma medications, the eye drops 1, and also orally. On day 5 after the surgery, because the IOP were already good on both eyes, we decided to stop the acetazolamide and also potassium L-aspartate, and we continued the other medication due to good IOP on both eyes. However, 2 weeks later, she came with high IOP on both eyes. You could see the right one was 46 and the left one was 22. So in this hypertensive phase, we switched the prednisolone acetate into fluorometholone eye drops, and we added again the anti-glaucoma medications orally with half dosage. This is her last follow-up, which was yesterday. It is already 6 weeks after the left surgery. We found a good IOP on the right eye with 11 millimeter mercury. And for her left eye, it was also good, 7 millimeter mercury. What we found a new one here is a white material, which was stick into the anterior capsule of the lens, extending into the edge of the tube but it didn't clog the tube. So we proceed the medications we stop the acetazolamide and potassium L-aspartate. We still advise her to use the fluoromethalone 4 times for both eyes. And we advise her to use again the navazoline and carmelosodium due to recurrent complaint of itchiness on her both eyes. So here is the recap of left post-operative IOP evaluation. The question will be, if we encounter a patient like this, we can also think of any other differential diagnosis such as juvenile open-angle glaucoma besides steroid-induced glaucoma. So to refresh our mind, vernal keratoconjunctivitis is actually a common pediatric condition that was treated by topical corticosteroids. So it is a chronic atopic disease, and many patients require steroid use at some point during the course of their treatment. But unfortunately, children are more likely to exhibit steroid-induced glaucoma than adults. And in children also, the IOP elevation and resultant glaucomatous damage can be more severe, more rapid in progression, and earlier in onset than in adults. So even after as little as 1 day of steroid use, this complication may not be reversible in certain individuals. Meanwhile, patients with juvenile open-angle glaucoma have a wider age range between 3 to 40 years old. And sometimes the IOP could be extremely high, even more than 40 or maybe 50 millimeter mercury. And we should keep in mind that juvenile open-angle glaucoma is caused by MYOC gene mutations. That's why it is important to ask whether the glaucoma runs in the family. So what's is the moral of the story? Steroid eye drops are everywhere, and it is easily found in the marketplace. So actually it is concerning because primary care doctors nowadays can prescribe the steroid eye drops without the capacity to monitor IOP. Given the possible devastating visual consequences, children who are given steroid eye drops should have a regular and also a frequent measurement of IOP. Regular clinical ophthalmologic evaluation is crucial to detect potentially damaging IOP evaluation. And the last but not least, the patient education is important. So in the post-operative period, evaluation and also management of IOP are mandatory. Not only the clinician, but also the patient should have awareness and also preparedness for the possibility of ups and downs of the IOP. This is the end of my slide. Thank you so much for your kind attention.
Okay, thank you very much, Dr. Carennia, for the interesting case presentation. I hope we can learn a lot from this case. Maybe before I screen the question from the chat box, may I ask a comment from Prof. Morgan regarding this case, Prof. Morgan?
Yes, thank you. Yeah, it's a very interesting case. So it highlights the problems of steroid use in children, and particularly vernal catarrh, where it's very tempting to use. So that's one take-home message. The other is the often very rocky course post-tube insertion, so GDD insertion. So this is quite typical, kind of, unfortunately. And so when you're doing GDD surgery, you have to expect problems with pressure, either the pressure going too low and then going too high. And I wonder, that left eye with what looks like fibrin on the lens extending into the tube, happening at about 6 or 7 weeks. I've seen that a few times just after 6 weeks when the stitch around the tube dissolves, because I'm assuming the surgeon put a vicryl tie around the tube, and that probably dissolved at 6 weeks. and then you get a traumatic flow of aqueous. And sometimes, because that happens when they're not in the clinic, and then they're at home and the anterior chamber goes flat and they get a fibrinous reaction, and fibrin plugs the tube temporarily and the pressure goes back up, but then the fibrin's left sitting on the lens. So what I would suspect that happened. I'm interested to know if the technique at surgery involved using vicryl tie, and if the tube was completely tied off, or whether it was a sort of tight but allowing some flow down the tube. What method was used, do you know?
Yes, Prof. Morgan, actually, this is my case, so I'm glad to get some input from you. And so I think when I did the surgery, I tend to tie it until there's no flow.
Yes.
Yes, because I'm quite too afraid to let some flow. Maybe I'm not as good as Dr. Firna while maintaining the low flow. So I tied it very tightly. So actually at the first there's no flow. So I also wonder why there's like fibrin in the 6 weeks. Yeah, Dr. Rere. So makes sense that what you told. And so do you think in the case like this, do you have maybe other approach for this kind of case? The first one is I want to ask about the post-operative steroid. Regarding this one is case of steroid-induced glaucoma. Is there any difference while you give the post-op management in this kind of case than the other kind of case? Because we want to like reduce the inflammation due to surgery, but we know that this patient is actually a steroid responder, which you have like different approach. Yes.
No, I wouldn't. Did you use a slit? Do you put a slit in the tube at the time of surgery? A Sherwood slit?
No.
No. That's probably the only difference I would do. I tend to routinely put a slit in the tube so that you get a little bit of flow. So but where you tie off the tube, between the tie and the anterior chamber, at least 1 millimeter away from the tie, I put about a 1 or 2 millimeter slit with the knife in the tube, so you get a little bit of flow. But look, it's very variable, and lately I've been using a wick as well as a slit, but I'm not certain. I still find that it's very unpredictable what the intraocular pressures are straight after surgery, and really you're on a roller coaster for the first 6 weeks, I think, whatever you do. But yeah, but you might like to try the slit, perhaps. It does help sometimes.
Thank you, Prof. And for this kind of case, is there any place for like traps?
Yes, there is. You could try a trab. But as you know, trabeculectomies fail more easily in children. So I think it's hard to know which way is best, whether to go straight for a GDD or do a trabeculectomy first line. GDD is more likely to work long term, but you can make an argument for doing a trabeculectomy, and I have seen trabeculectomies in some children work for a very long time, but I suspect they're unusual. Often they fail. But this child is possibly going to need steroids for quite perhaps for the vernal catarrh. Did she have cataract? I think you mentioned that there was a bit of cataract. Yeah, so that's another reason not to use the steroids. But look, you can make a case either way for doing GDD or for a trabeculectomy. I don't think there's not a definite answer there, I don't think.
Thank you, Prof. So I think there's no question for now. So how about we proceed to your lecture first, Prof?
Well, thank you. I shall just go, I'll share screen. And sorry. Can you see that?
Yes, clearly, Prof.
Okay. Oh, and look, I thought I would talk on, and the title's very pale, trabeculectomy and its technique. And it's a very basic talk. I just wanted to, a little bit of history. It was first described in 1968, so that's a long time ago. It's 55 years ago this year. And the original idea was to excise a little bit of trabecular meshwork and allow, if you like, aqueous humour to have direct access to the canal of Schlemm. But then it was realised that, in fact, you didn't have to remove trabecular meshwork, and that the aqueous was actually draining into the subconjunctival space and not into the canal of Schlemm. So that shifted the aim of surgery to basically create a trapdoor or a channel through to the anterior chamber, covered by a scleral flap, allowing aqueous to go into the subconjunctival space. But the name of trabeculectomy stuck, even though usually we don't remove any trabecular meshwork. So why do a trabeculectomy? It's really done when the glaucoma is progressing in spite of maximal medical treatment and a consideration of laser and understanding the particular risks. So here's a couple of examples. On the left is a patient with progressive glaucoma, and you'll notice two disc rim hemorrhages in the same optic disc, one at about 7 o'clock and the other one at about 10 o'clock. So this patient is progressing. And on the right-hand side, you can see quite rapid visual field loss as well. So they're two reasonable examples of progression. It's very important to tell the patients what they're in for, and that this surgery will not improve their vision. That's the first important point. And that about 13%, in fact, from one study, will notice a slight reduction in visual clarity. So their visual acuity may be slightly worse, particularly in patients who have 6/5 vision or 6/6 vision. But there is a risk of blindness. And if they have severe glaucoma, there's a risk of snuff out or further visual field loss, and also a risk of central retinal vein occlusion, and that the eye might not feel quite the same. The bleb can give an unusual feeling sometimes. And that the success rate is, I think, about 95% on average in terms of giving a reasonable, significant pressure reduction for at least some years. Now, we like to think we can aim for a certain pressure, but really it's highly dependent on the patient. But if we can aim, we will generally aim for a pressure between 10 and 15, occasionally less than 10 if possible. But you don't really have that much control over what pressure you end up with. If you do get a pressure less than 5 or 6 millimeters, then that can cause trouble with choroidal effusions, especially in myopes, where it can also cause macular problems. And so some of the surgery, one of the advantages of trabeculectomy with the scleral flap covering the ostomy is that hypotony or low pressure is a bit less common than with full thickness procedures. Now, a lot of surgeons will argue about whether you should do a limbal or fornix-based flap, but I think it's really dependent on your own preference. And here, this is quite a nice meta-analysis published 10 years ago. And look at the very bottom diamond. They analysed a whole lot of studies, some of which favoured limbal-based flaps, some favoured fornix-based flaps. And it's pretty much equal. There's really, if anything, there's a slight tendency to favour a limbal-based flap, but really there's nothing significant between the two. So whatever you're comfortable doing and feel safest with is probably the way to go. Next question is, should you use an antimitotic such as mitomycin C? And these days, mostly yes, particularly if the patient has had cataract surgery or has been on topical drops for a long time, which most of them have. Also, if they're young, then they tend to scar more. And if there are other risk factors, so we mentioned previous cataract surgery, but any other eye surgery, multiple eye drop use, uveitis, and trauma. Now, if they are very elderly or if they're immunosuppressed, then consider just using 5-fluorouracil or even no antimitotic. Or if you're worried about the conjunctiva, if it looks incredibly thin, then you might decide not to use mitomycin C and just use 5-FU. And then the preoperative check should always include an examination of the angle. And what you are looking for are signs of ciliary block or the volcano sign in particular. So, and also if there is a cataract, because generally a trabeculectomy will make a cataract worse, and you'll wish that you had removed the cataract first. So if possible, if the pressure's not too high and they have a cataract, remove the cataract first. If the pressure is quite high and they have a cataract, then you may consider combining the surgery. So also check the conjunctiva. Is the conjunctiva healthy where you're going to operate? And also, is the patient on anticoagulants and likely to bleed? Now, the anesthesia, most times we will do this under a local anesthetic, which involves a subconjunctival injection. And this is quite safe. There's very little chance of a serious hemorrhage, but the patient's eye can move a bit. The other option is general anesthetic, but we don't use that very much. Now, I'm keeping this quite simple. I'd say that there are 10 steps, and I'll go through the steps. There's fixation of the eye, conjunctival incision, diathermy, the outline of the flap, and then apply the antimitotic, then cut the scleral flap, do a paracentesis, cut the ostomy, and then a peripheral iridectomy, suture the flap and close the conjunctiva. And I'll go through these steps one by one. So it's very important to fixate the eye. So to get the eye in a good position so you've got good exposure. Here I'm just removing an eyelash, I think. And I'm about to put a 5-0 polyester or Vicryl with a spatulated needle through the cornea. Notice that I'm using closed forceps as countertraction. I'm not grabbing the conjunctiva because I don't want to tear or cause a conjunctival hemorrhage. So the suture has gone through the mid-stroma of the cornea, and I'll pull that through, and then I can pull the eye down. Now the conjunctival incision. I'm going to create a radial fold with the Moorfields forceps. So notice the radial fold. I'm going to cut right down to bare sclera. And now I've cut down to bare sclera. I'm checking how far I need to go. I'm noticing the thin conjunctiva on the right-hand side. And I'm going to stay away from that very thin region in this particular case. I'm cutting through some tenons. And notice I'm blunt dissecting forwards. I'm not cutting forwards to the limbus. And I'm also not cutting right up to the limbus or blunt dissecting right up to the limbus. I'm allowing that connection between tenons and the sclera to remain reasonably intact right at the limbus. I'm making sure I've got good exposure posteriorly. And in this example, because of the conjunctiva, the patient was on an immunosuppressant, I decided to use 5-fluorouracil. Now, before I apply the antimitotic, I'm outlining the flap, and I'm only applying diathermy to where I'm going to cut. So I do not burn the entire sclera. I only apply where there is the track, where I'm going to actually physically make the incision, because there's no need to burn any of the other vessels. you simply create more scarring. And I don't want to create excessive scarring. I want to minimize the scarring. So notice the diathermy is applied only to where the track is being cut. Now here, I'm actually using 5-fluorouracil, and you will notice that I'm applying it over the flap. Oh, hang on, maybe I'm not. This might be, no, I think you're about to see me putting it over the flap. Yeah. Now, with mitomycin C, I will never do this. I will always put the mitomycin C on a pledget posterior to the flap, so under the posterior conjunctiva, because I do not want to get an ischemic bleb or ischemic conjunctiva right over the scleral flap. So there's a difference in terms of how I apply the 5-fluorouracil compared to the mitomycin. With the mitomycin, I'll only ever put it well posterior to the flap under the posterior conjunctiva and do that for 3 minutes. So remove the mitomycin or the 5-fluorouracil. I'm going to make the incision now. Here I'm using a diamond knife, but I usually use a steel knife, following exactly in the track that we've done the diathermy. And I cut about half thickness sclera, and I watch the bevel on the blade to give me a gauge as to how deep I'm going. So I've hit a small vessel there, which may or may not need diathermy. No, it looks like it's stopped. And we're going to then just bring the incision across. So now I'm going to cut the scleral flap, and I'm going to use what we call a hockey stick blade or a shelving blade. And notice I'm going to, when you see me cutting the flap, I'm actually pulling up on the sclera quite firmly, and I'm really dissecting in a plane, and I'm using the blade to just sweep away adhesions in that plane. And I'm also making certain that I cut the adhesions right at the left and right-hand sides, so that the incision, if anything, looks like a smile. So most residents, when they first start doing a trabeculectomy, do the opposite. They're worried about cutting the edges, and they cut more in the middle, so it ends up looking like a frown. But as you get closer to the cornea, it becomes very difficult to see the cornea if you do that. So you want to end up where you've got a nice cut right up to the limbus, and you can then expose the cornea stroma nicely to give you a chance to have a decent ostomy. So here's the scleral flap. Notice I'm sweeping left and right, just going back and forth. I will re-grasp the flap. So for the first time, when you first start doing a trabeculectomy, this is sometimes one of the hardest parts of the procedure, because it seems unusual that you pull up so hard on that flap. And it's also unusual to literally sweep away adhesions with the blade. Notice that I pause ever so slightly at the left and right-hand edges. That's where I'm making certain that I'm cutting those edges so that I do not create a frown. Now I'm getting close to surgical limbus here, and I'm just making sure that I'm cutting those edges, and you can see cornea now. See how we're getting into clear cornea? Yes, so see that? It's almost far enough, actually. But I like to have good exposure. I don't want to, when I cut back with the ostomy, I do not want to cut into ciliary body, because you can get very bad bleeding and hyphema. So now I do a paracentesis now, so that I can refill the anterior chamber during the surgery and also in the first few days post-operatively, if necessary. Now I'm going to cut the ostomy into clear cornea. I'm going to make a horizontal or a vertical incision, but left to right. It's actually from right to left, and then bite back with the Kelly punch. So here, notice how I'm holding the blade. It's vertical. I'm cutting right to left. So I can see the aqueous come out, and we'll probably dab the aqueous humour in a minute. No, I'm going straight for the Kelly punch, and I'm holding the Kelly punch vertically. And there's a little bit of iris prolapse, which you just have to be careful of. And usually 2 bites with the Kelly punch is sufficient. One thing, I'll just pause one thing with the ostomy is to make certain that you're through Decimase membrane. So you should always check that you've got a clean hole through the entire corneal stroma. Notice how I do not go back into trabecular meshwork tissue. There's no need to do that. That risks cutting into ciliary body and creating a hemorrhage. But I'm careful about looking that I'm all the way through, because it's easy to cut and miss the Decimase membrane, and then Decimase can actually block the ostomy. So be careful of that. So now cutting the peripheral iridectomy. This is the only part of the procedure where it's very important to have an assistant. Notice how the assistant is grasping the scleral flap. So I've instructed them to hold the scleral flap down towards the cornea and to grasp it fairly firmly. Put a little bit of pressure on the anterior chamber and cornea, which will cause the iris to prolapse, so that you do not need to go in and hunt for the iris usually. If you have to go deep with your forceps to grab the iris, there's a risk you can grab zonules behind the iris, and as you cut the iridectomy, you cut through the zonules and the vitreous may appear. So if you can, try and get the iris to prolapse, and then it's much easier to grasp and it's safer as well. So we'll finish watching this. So here I've cut the peripheral iridectomy with the long-bladed small scissors, and I'm just checking I'm through. Yep, I'm through. I've cut through the pigmented layer of the iris as well as the non-pigmented layer. Now, suturing the flap, I use 10-0 Vicryl. Some people use 10-0 nylon. I like Vicryl because it dissolves and you never see the suture, but it's not always available and it is more tricky to use. Notice that I'm suturing the corner of the bleb. The corner of the bleb away from 12 o'clock. And I'm suturing that down with an interrupted suture. And if anything, I'm going to try and encourage the bleb to form closer to 12 o'clock. So that's one interrupted. I usually put another one in the middle there as well. So I'll have 2 interrupted sutures. And now on the 12 o'clock side, I'm going to put in a releasable suture. There's different ways of doing this. This is just one technique. So I'm passing the suture through both the bed of the sclera and also the flap. I'm going to pass the needle through corneal stroma in a minute. So you'll see the needle come through the corneal stroma. And I like to exit a fair way from the limbus so you don't get cheese wiring into the conjunctiva and get a leak. So this is important to avoid damaging the conjunctiva. So notice I'm going back to cornea and I'm coming back into that subconjunctival space. And I'm going to tie the end, so the beginning end of the suture, to a loop. Find the suture. Oops, I've missed the throw. I think I've lost where. Sometimes it's hard to find the loop, actually. There is the loop there. And I've put 3 throws onto a loop, and now it's a slip knot, and it's just a matter of cutting the ends. And because I've gone out the cornea and then back in the cornea, there is a loop on the cornea, which you can find at the slit lamp and pull out. So now I'm closing the conjunctiva. When I took this video, I was using 10-ovicral, but most times these days I use 8-ovicral because it's a bit stronger. And I had 1 or 2 cases where the 10-o broke and there was a leak, and I had to put some more sutures in. So with 8-ovicral, it's stronger, and I don't think I've ever seen a leak from the conjunctival wound. And it is one advantage of the limbal-based flap, that the closure of the conjunctiva further back with that thicker tenons is really very secure, and it's very unusual to get a leak. But as I said at the beginning, whether you do a fornix-based flap or a limbal-based flap is really surgeon preference. If you are doing a limbal-based flap, then when you close, it's very important to pick up conjunctiva and tenons so that the tenons is opposed to each other and tends not to stick to, notice how I picked up tenons separately there, and again here, so that the tenons is held somewhat elevated away from the sclera, because you want the bleb to try and pass posteriorly beyond the wound. So this, I'll stop here because you don't want to see me putting a whole bunch of stitches in. But basically that's the end of the trabeculectomy. So the idea is for the fluid to pass through the peripheral iridectomy, out through the channel into the subconjunctival space and create a bleb. Now, I will just show you, this is a slightly more recent one with using mitomycin C. Again, corneal fixation. That's doing the incision. Blunt dissection down to the limbus. Outlining the flap. And this is where I typically put the mitomycin. So sometimes in these tight orbits, it keeps wanting to come back at you. But notice how I've pushed it down. And I've used a large pledget, so quite large, because they're easy to lose sometimes. So 2 large pledgets is usually enough. And then I'm cutting the flap and I'm timing for 3 minutes. I won't show you the rest of this because it gets a little bit boring, but I just wanted to show you where I position the mitomycin C in most patients. So a few more slides. Complications of trabeculectomy. On the left, the choroidal effusion. Top right, flat anterior chamber and hypotony. And further down, macular folds, again secondary to hypotony. So the immediate post-operative complications that we fear the most are generally related to hypotony or low pressure. So that's why we like a tight flap, and it's handy to use a releasable suture so that if the pressure is a bit too high in the first few days, you can pull out that releasable and attempt to bring the pressure down. Now, there have been lots of studies looking at complications. Probably one of the best traditional or classic studies of trabeculectomy outcomes was with the AGES study, and there's a list of complications here. They talk about IOP elevation, but really most people worry about leakage of the wound, synechia, choroidal effusions or detachments, and peripheral iridocorneal touch or other problems with hypotony. So here, another paper on complications. And again, the top most common one's hyphema, which in many ways is not really a complication, it's very common. But the complications really that we worry about all tend to be around having a very low pressure. So shallow anterior chamber, hypotony, leak, choroidal effusions, flat anterior chamber. Malignant glaucoma should be avoided if you carefully select the patients preoperatively, and do not operate on patients with a volcano sign unless you've taken out the lens or are taking out the lens at the time of surgery in most of those patients. Here's a B scan of somebody with almost kissing choroidal effusions. Now, the reasons for visual loss, so other complications after surgery, commonest reason down the track, so months or years down the track, is cataract. Next commonest would be progressive glaucoma, so if the pressure is not low enough, or if the glaucoma is very severe, so the cup to disc ratio is pretty much 1, very marked visual field loss, they may still progress, but at a slower rate. And then you have refractive changes, vein occlusion or decompression retinopathy does occur, but fortunately it's fairly rare, and then snuff out or wipe out. So here's an example of decompressive retinopathy or a central retinal vein occlusion after trabeculectomy. A serious complication is snuff out in patients with very serious visual field loss. And that I usually quote a figure of between 3 and 5% in patients with severe glaucoma. And I think it's worth doing that so that if you are unlucky or that patient is unlucky, at least you've warned them of that possibility. I think I should stop here. I think I've talked for long enough and give time for questions, because I could go on and on about trabeculectomies. So I'll stop sharing. Thank you very much, Mita.
Thank you very much, Prof. That is very interesting talks, and you have showed us the very nice videos. So I think we have some times to answer some question. Maybe I will read the question regarding related to the trabeculectomy first. Prof, the question from Dr. Maria Larasati. Thank you for Prof. Morgan for your very interesting and insightful talk. My name is Maria from Jakarta. Do you have any specific preferable trabeculectomy site? Is it the nasal superior or temporal superior, or right in the middle? Considering that the same patient might then need to undergo some other surgeries, such as
Yes, that's a very good question. So I never do it in the middle, because if you do it in the middle, it makes it much harder to do a second operation in the superior part. So it's always supranasal or supratemporal. I tend to do them supratemporal, but it's a historical reason, which is probably not important anymore. It was when we were developing the Zen stent, and I knew that the Zen stent was going to be commercialized and that it could only be done supranasally. I would tend to protect the supranasal conjunctiva. So for 10 years, I was doing all of my trabeculectomies supratemporal. But that doesn't really matter so much anymore, because you can, at least in Australia, we can put a Zen stent in if we want to now. So I don't think it really matters. It probably matters more if you're right-handed. It's easier to do supratemporal on the patient's right eye and supranasal on the patient's left eye. Yeah, that's basically what I do.
Thank you, Prof. For maybe in my hospital, I think we tend to do it supranasally, Prof, because we think that some of our patients maybe need the GDD later, and we are more comfortable to put it supratemporally. So in Western Australia, also some patient will undergo GDD, right, Prof? So
yes.
when they undergo the GDD, will it be put in the supranasally or?
To me, it doesn't really matter to me if it's supranasal or supratemporal. You're right; it's slightly easier supratemporally because of the exposure, but it doesn't really matter to me, actually. Yeah.
Thank you, Prof. And for the next question from Dr. Paramita, Prof. Good evening, Prof. Morgan. Thank you for the presentation. My name is Fitri from third stage of glaucoma division. I would like to ask 2 questions. The first one is, I realize that you prefer to use limbal-based conjunctival incision. Is there any particular reason for you personally why to use this method instead of the other one? And
Yes.
second question is about how to make the iris prolapse to perform the iridectomy safely, like you've said before.
Okay, so why do I do limbal-based flap? again, it's historical. So when I was training, 5-fluorouracil was just coming in. And then when I was a young consultant, mitomycin C was coming in. And the big fear was leaks. And so we had gone back to doing fornix-based flaps, but then because of mitomycin C, and we weren't sure of the dosing and the risk, we knew the risk of wound breakdown was higher and leaking was higher. So I shifted to limbal-based flaps, and I've never changed back because I've seen a lot of people do fornix-based flaps, and they tend to get more leaks than I get. And I like to basically do the surgery and go home and know that I'm very unlikely to have a problem. So I know that fornix-based flaps, fornix-based flaps are more popular. They're easier because the exposure of the scleral flap is easier. And also it's been promoted heavily by some groups in the United Kingdom as well. But interestingly, the meta-analysis shows basically no difference, or in fact, a slight possible benefit towards using limbal-based flaps. So, but I don't think there's a clear answer. It's whatever you prefer doing. And then the other question I've forgotten now. What was the other question?
About that you suggest that it's better to make the iris a little bit prolapsed to perform the safer, and how to do that?
Simply when the assistant grasps the scleral flap, just ask them to pull fairly firmly towards the center of the cornea and push a little bit on the cornea so that it pressurizes the anterior chamber, and that will tend to push the iris up into the ostomy. It doesn't always work. So sometimes the iris is stubborn and it sits down there in the well and you have to go and grab it. But more often than not, it forces the iris to prolapse a little, and then it's very easy to grasp.
And are you always sure that the iris part that are prolapsing is the really the peripheral one? Because sometimes when we
I see. Yes, I'm quite confident that it's the peripheral part. Yeah.
Thank you, Prof. And so we have more question from Dr. Widya Anandita. Thank you for your detailed talk, Prof. Can you please elaborate more on how you manage the bleb during the post-op period? When do you take out the releasable suture? Do you make your patient do the massage on the bleb or not?
So the first question was
about how to manage the bleb. First one is related to the releasable suture.
That's probably a topic for another talk. I could speak for half an hour on managing. Bleb management is quite complicated, and it's almost as complex as the actual surgery itself. The short answer is, well, there is no short answer, but in essence, you're looking for a nice diffuse bleb without too much vascularization, so not too much inflammation. And the management involves using, in my hands, 5-fluorouracil. Also, potentially, if the flap is too tight and your releasable has not worked, you may need to give 5-fluorouracil, but also pass the needle under the flap and elevate the flap physically. So there are some maneuvers you may have to do post-operatively to force, if you like, aqueous to flow into the subconjunctival space, but also to inhibit excessive scarring or vascularization. And then there's the management of overdraining blebs as well. So if the pressure is too low, there's no leak, but there's a very large bleb, then what do? Normally time will fix it, but you reduce the topical steroids and any other anti-inflammatory agents and wait, but you may be forced to reform the anterior chamber or even suture down the flap. So it depends, and it's really the subject of another talk, actually.
And When is the earliest you put out the releasable, and when is the last time?
Yeah, good question. I virtually never pull it out on day 1, day 2, and it depends. And then when's the last time that you can pull it out where it might have some effect? That depends upon the antimitotic. So with 5-fluorouracil, you've got a window. It's really a window of opportunity, which is only a few days with 5-fluorouracil, whereas with mitomycin C, it's probably 1 to 2 weeks. After that, it may not make much difference because the body is forming fibrin and starting to scar down the flap.
Yes, thank you very much, Prof. And how about the bleb massage? Do you think it's working? And will you educate the patient to do it by themselves, or you just do it on the slit lamp?
Yeah, look, we used to, 25 years ago, we used to do bleb massage, but I found, at least I didn't have much joy with it. I found that most times the pressure it brought the pressure down immediately, but then the pressure would often go up straight afterwards. Now, I have actually, in the immediate post-op period, if you think that the flap is stuck with fibrin, what I have done sometimes is used a cotton bud in an anesthetic and put a bit of pressure just behind the flap, and that sometimes causes the flap to lift up and then the pressure to come down immediately, which is kind of like massage, but it's massaged by the surgeon at the slit lamp in a controlled manner. But the sort of, I think, ocular massage you're talking about is where the patient presses on the eye, presses a few times, comes off, presses, and does that. You do get a pressure reduction, but then half an hour later, the pressure's back up to what it was. Short answer is I don't really do that. No, it usually means the bleb you've got to manage the bleb, basically. Yeah.
Thank you, Prof, for a very clear answer. And actually, we have passed our time, even though there's just a few questions. Maybe just can we answer like one more?
Yeah, sure, absolutely.
Yes. Okay. Okay. The last one maybe from the Dr. Michael, and he asked whether when you choose the 5FU instead of the mitomycin C, maybe some of it have you have explained before, yeah, regarding the patient selection for the 5FU or MMC. Maybe there's something you want to add, Prof?
Yeah, no. So my default or usual position is to use mitomycin C. But if I see the conjunctiva very thin, or if they're on immunosuppressants, or if I'm worried in some other way, for example, if they've had the other eye done and had a massively overdraining bleb, which was a problem, then I'll use 5FU. Usually both eyes behave about the same, unless there's a trauma or some problem. Yeah, but that's basically it. I mean, we have a different demographic. Most of our patients are Caucasian, and they don't tend to scar as much as Indonesian patients. So that's another factor. So I think probably almost all of your patients would require mitomycin C. 95% of our patients require mitomycin C. It's only 5% where we don't use it, basically.
Yes, all right, Prof. I think we have like a patient with a high risk of fibrosis here. So all of our patients have mitomycin C in the traps. And also we are not too afraid about the leakage or thinning of the
Yeah.
flap. So sometimes in some patient also we don't, we do it like we don't want to flush the MMC too much sometimes because usually the fibrosis is quite vigorous, Prof.
Yes, that's correct. Yeah.
Thank you, Prof. I think because we have now passed the time, we can conclude the meeting. We have here Dr. Firna. Is there something do you want to add, Dr. Firna? No? Okay. Thank you so much, Prof. Thank you, Dr. Carennia, and all the participants joining in, and also the consultant. Before we close the meeting, just as usual, so we want to take pictures first. Dr. Miki, can you help us?
Yes, Dr. Mita. Thank you for Prof. Morgan and Dr. Carennia for the presentation. Now I'd like to invite everyone to turn on your camera, please, so we could begin our picture session shortly. Okay, we will wait for 10 more seconds. Okay, now I will begin taking the picture. Give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. And the last one. 1, 2, 3. Okay, that will be all. And I would like to remind everyone to fill out the attendance form in the chat box below. Thank you.
Thank you. Thank you very much, Dr. Miki. Thank you very much, Prof. Bye, everyone.
Thank you. Thank you very much, Mita. Thank you.
Thank you, Dr.
Good.